Hi, everyone. Welcome. We're just waiting for people to start trickling in. I'll make an introduction here in the next minute or so, and we'll get started. I know some people might be running a few minutes late, but I see a number of people here. So I'll just start off with a quick introduction. First off, happy to have everyone here. Thank you so much for joining us. We've almost, I believe this is now marks our 12th monthly webinar that we started last June. So we're thrilled to be doing this again. And as you've noticed over the last year, what we have done is continue to build out our network of specialists to give clients more and more access to people and to services that intersect kind of overall financial planning and wealth management, but have very specific kind of niches and parameters associated with them. And Medicare obviously is a huge area of interest for our clients and one that has plenty of nuances. And we're so happy to have Margo Steinlage with Steinlage Insurance Agency joining us today. She's actually going to be giving the webinar. And the way we're going to handle it is Margo's going to go through her slides. And then towards the end of the presentation, we're going to leave some time for questions. So if you want to type your questions into the Q&A box, and then Margo will make sure she addresses that at the end. And if you want to schedule a time with Margo, she'll talk about how you can get a hold of her at the end of the presentation. So Margo, please take it away. Thank you so much for joining us.
Awesome. Thanks for the introduction. And thank you all for joining me on this Master Medicare webinar. A little bit about myself. I'm originally from St. Louis, Missouri. I moved here about 5 years ago to Virginia. And opened up our second agency office. Our agency, we're family owned and operated. We've been in business. My grandfather opened the agency in 1950s. My dad took it over, and now myself and my two brothers we're operating and running the agency. We're very specific in what we do. What we do is help individuals who are aging into Medicare at 65, or if they're working after 65 and now retiring, we help them navigate this entire Medicare market, whether that means enrolling in Medicare, appealing your income surcharge, picking out your supplement, your Advantage plan, drug plan. We help you navigate that entire arena. There's no charges for our services. So whatever plan you end up selecting, if and when you opt into Medicare, that plan will pay us a finder's fee for bringing in the business. So one way we are able to stay neutral with our assessments and portfolio is that we get appointed with all national carriers to sell their Medicare products. So if you're looking at the supplement market, the drug plan market, or the Advantage plan market, we are licensed and appointed with all carriers in that arena. And that's something we take very seriously. Every year we get appointed with these carriers so that when we sit down with you, we are able to give you a neutral position that's based on your specifics, your prescriptions, your doctors. Are you working? Do you have a spouse on the plan? Do you have dependents on the plan? So that's something we take a lot of pride in. Also, as Obamacare has developed over the last 5-10 years, we've really helped assist clients who are in the market for Medicare if they may have a younger spouse who's coming off group coverage or retiring and needing Obamacare for a gap year or two to get them into Medicare, or children who are coming off their adult or their parents' plan at 26. We help them navigate the Obamacare market. In majority of states, there's a handful of states that don't use the federal marketplace. And in those states, we are unable to assist, but we can provide general guidance. So anytime there's a health insurance question, I'm happy to at least point you in the right direction if it's something our agency specifically does not handle. Also, what we do is we give free annual reviews for our clients. So once you enroll, this isn't a one and done interaction with me. We help you enroll, we help you select your plan that's based on your needs this year. And then every year we reach out proactively to our clients, asking for updated prescriptions, asking if you've moved, asking for anything that's new for you so that we can give you a recommendation for the upcoming year. We are licensed in the majority of states for Medicare. Again, Obamacare and ACA products is slightly different. 95% of what I do is Medicare related. This is a little bit dated on our slide. I would say we are in 40 states out of the 50. Anytime we get a new client, we can turn around and get appointed. So if you have family members that are out of state, we see that often. We can help those family members. I know a lot of clients are out of state for me. So again, we aren't based specifically in Virginia. We help Maryland, DC, nationwide. So today we're really going to jump into 3 moving parts of Medicare. First, we're going to hop into who's eligible for Medicare and what does that look like? What does the sign-up process look like? Then we're going to jump into Medicare products and the terms. What's Medicare A, B, supplement, Medigap, Part D, Medicare Advantage? What do all these moving parts mean and how do they work together to give you comprehensive coverage? Then last, we're going to look at regulatory changes. We're going to cover the donut hole, IRMA, if you're a high-income individual, and a recent regulatory change called the Insulin Savings Program. We're going to touch that towards the end of the webinar. So if you are a high-earning individual or if you have a prescription drug that's pretty expensive, we'll hop into the donut hole and IRMA discussion towards the end of the webinar. Also, I just want to take a note to mention that I do have a lot of federal employees and retirees through the federal government that call. I don't work specifically with or for OPM or with the federal employee health benefits. If you need assistance in signing up for Part A and Part B, we can hop on the phone for 15 minutes, but generally I recommend steering you towards the OPM or the Anthem Blue Cross Blue Shield for the federal specific product, the GIHA, because they're going to be much more knowledgeable because that is an arena that we don't work in. But this webinar for general Medicare information will assist the federal employee, but the products that I sell are geared towards private employees. So somebody who's not working for the federal government and coming off group coverage. All right, so first segment here, who is eligible for Medicare? So the general rule here is that anyone who is turning 65 is required to sign up for Medicare Part A, hospital, and Part B, medical. So that's the general rule. If you don't sign up for Medicare at 65, then you'll see penalties down the road if and when you pick up Medicare. So the general rule is that Medicare wants you to sign up at your 65th birthday or birth month. The exception to that rule is unless you are working for a large employer, you or your spouse are actively working for a large employer, then you can delay Medicare Part A and Part B enrollment. So general rule, you need to sign up for Medicare at 65 to avoid penalties. The exception to that rule is unless you're working for a large employer with active group coverage. And we'll jump into that here shortly. So you're required to sign up at 65. If you're under 65 and you're on disability for 2 or more years, then you're automatically enrolled in Medicare Part A and Part B, even though you're not 65. Also, if you have an end-stage renal disease diagnosis, you're automatically enrolled in Part A and Part B, regardless of your age. Now, if you're collecting Social Security prior to turning 65, you will be automatically enrolled in Part A and Part B when you turn 65. So if you're collecting Social Security, then Medicare and Social Security are in cahoots. They're talking to one another, and they are automatically enrolling you in Part A and Part B for your 65th birth month. If you're not collecting Social Security at 65, then you need to proactively opt in or proactively enroll in Medicare at 65. And you have a 3-month window before your 65th birth month to enroll for an effective date of your 65th birth month, the first of your birth month. And you have a 3-month window after your birth month to avoid any penalties. Once you sign up for Medicare, Medicare will either draft your monthly premium directly out of your Social Security benefit, or it will bill you quarterly for your Part B premium and any IRMAs that you owe if you're a high earning individual. So let's go back to that exception to the rule. So if you're turning 65 and you are on small group employer coverage. So if you're turning 65 and your employer who you have group coverage is under 20 employees, then you must sign up for Medicare Part A and Part B in the majority of cases to avoid any penalties. If you are working after 65 and it's a large employer, 20 or more employees, through either your group coverage or your spouse's active group coverage, then you can delay Medicare Part A and Part B without any penalties. Medicare becomes optional. Your large group plan will remain primary status. And so what this means is you can stay on your group coverage, delay Medicare A or B enrollment, and then when you or your spouse retires, that creates a special enrollment period that allows you to get into Medicare Part A or Part B upon retiring without any penalties. A few notes here. If you retire from large group coverage and now you have COBRA, COBRA is not deemed active coverage. So you need to sign up for Medicare Part B when you retire to avoid penalties. Also, if you're turning 65 and you're on group COBRA, you need to sign up for Medicare A and B at 65 to avoid penalties. COBRA is not active coverage. Also, a red flag to watch out for is if you're on this large group plan and you decide to delay Part A or Part B, you need to watch out and double check to see if you're making contributions into a health savings account, an HSA. If you are contributing into an HSA and you enroll in Part A or Part B of Medicare, you can in most circumstances, you can no longer make those contributions and stay in Medicare A and B. So IRS doesn't want you to have Part A Medicare and a high deductible group plan and make HSA contributions. So in most circumstances, if you're on large group coverage, making health savings account contributions, you'll want to delay both Parts A and B until you retire. That way you can maximize your contributions for the foreseeable future until you retire. Also, when you do plan to retire and you sign up for the Part A and Part B, your Part A will have a 6-month retroactive effective date from the day you start your enrollment process. So this is something to plan. Usually I recommend reaching out about 9 months prior to your desired retirement date if you're contributing to an HSA, so that we can make sure we stop these HSA contributions prior to that 6-month retroactive look back. And this is pretty specific. So if you have questions revolving around HSAs and group coverage, shoot me a private email. Typically what I do in this scenario is I'll ask you as a client, what's your group coverage? Do you have any dependents on the group? Do you have a spouse that you're covering on the group? What's your spouse's age? What's the premium? What's the deductible, the max out of pocket? What's your income? How does your group plan compare to Medicare? Does it make the most sense to stay on group until you retire because it's very competitive? Or is Medicare more competitive than your, $800,000 group plan? So we'll compare that. It's a very easy process. I do it all the time, but I'll need additional information. And this is where it becomes, my advice becomes very client specific because your plans are all different. Also, once you move into Medicare and you come off your group plan, if you have contributed into your HSA over the years, you can begin using those HSA contributions after 65, once you're on Medicare, for basically everything Medicare related, everything except for your Medicare supplement premiums. So your HSAs can be used for Medicare Part B, any income IRMA surcharge, your Part D premiums, your Medicare Advantage premiums, any co-pays, deductibles, everything except for your Medicare supplement or Medigap premiums is on the table. All right, so next part of our webinar here, what are these moving parts that I keep talking about? What is Part A? What is Part B? And kind of what's the big picture here? So in the blue box here, you'll see two moving parts. You have the Part A hospital and Part B medical. These two parts make up original Medicare. So when somebody says, I have Medicare, they have Part A hospital and Part B medical. For most of you, the Part A hospital benefit will be a zero premium per month. There's no income adjustment on the Part A hospital. Most people have a zero premium for Part A. A handful of you, if you don't have work history, you didn't pay federal taxes, and you don't have 40 quarters worth of work history through your work or your spouse's work, then you have a premium that's attached to your Part A. Very rare that I see this. Most people will have the zero premium for Part A. Then you'll have the Part B medical portion of Medicare. The standard rate for Medicare for this year is $148.50 per month. If you are low income and with your income and assets, you qualify for Medicaid, then Medicaid may help pay for this Part B premium. If you are high income, then Medicare will add a surcharge or an additional premium to your Part B standard rate, the $148.50. That's called IRMA, and we'll jump into that later on in the webinar. But two moving parts, your hospital A and medical B. Once you pick up Medicare A and B, in a nutshell, it's covering 80% of the bills. You do have a Part A hospital deductible of roughly $1,500, $1,484 to be exact. And this resets every 60-day occurrence. So let's say you go in the hospital June 1st for a hip issue, and then on November 1st, you go in for a heart issue. Two different occurrences outside of the 60-day window, your deductible resets. Then you'll have a Part B medical deductible. For this year, it's a $203 deductible per year. So once you meet the $203 deductible, Medicare's covering 80%. These are the gaps in Medicare. Your Part A, 60-day occurrence deductible, your Part B, annual $203 deductible, and the 20% coinsurance after you meet your deductible. So this is where all of these ancillary products come into play. They come in to fill those gaps in Medicare. You'll see that for anyone who's non-federal government employee, you'll have two options to choose from. You'll have the supplemental plus a drug plan route versus option 2, Medicare Advantage Part C. If you are a federal employee retiring and moving to Medicare, Medicare would be your primary, and then your federal employee benefit would be a third option here that you would keep. It would be your secondary after Medicare pays. Again, that's all through OPM and the federal employee benefits. For everyone who's non-federal, you're looking at two options. Option 1 is you have original Medicare as your primary payer, then you pick up a supplement and you have a drug plan that covers prescriptions. Versus option 2, Medicare Advantage. Let's dive a little bit deeper into each option. So option 1, and actually let me take a step back. No matter which route you choose, this standard Part B premium plus any income surcharge is standard regardless of the option you choose. You will always pay this Part B premium. So if you select option 1, you are choosing to keep Medicare as your primary payer. So you have Part A, Part B. When you go see a doctor, they ask who's your primary, you state Medicare. You can go to any doctor nationwide that takes or accepts Medicare. Then you would pick up a supplement. This is where you have Plan G, Plan F, Plan N, all these different letter supplements. They are coming in to fill the gaps in Medicare, that Part A deductible, your Part B deductible, and that 20% exposure. So you show your original Medicare card as your primary payer, and then you follow it with your secondary card, your supplement. You would never ask a doctor, do you accept my supplement? Because they'll think you're in an HMO or PPO. You'll always ask, do you accept my Medicare? If yes, then my supplement, regardless of carrier, is mandated to pay. So within the supplement world, you have Plan F, Plan G, Plan N. Those are the most popular plans. Plan F covers 100% of your gaps after Medicare pays as primary. You show your plan Medicare card, your Plan F card, you have 100% coverage. Plan F is no longer available to you if you are turning 65 after January 1st of 2020. If you enrolled in any portion of Medicare prior to January 1 of 2020, you are grandfathered and you can shop around your Plan F. But for anyone brand new to Medicare, you cannot access Plan F. Plan F is slightly higher in premium and offers 100% coverage. The Plan G is a step down from Plan F, and it is identical except that you are paying your annual $203 Part B deductible. So you show your Medicare card, you show your Plan G as in girl supplement card, you have 100% coverage for medical and hospital, except for that $203 per year deductible. Plan N is one step down from that. You show your Medicare card, your supplement N, you have the $203 per year deductible, a $20 copay for doctor visits, a $50 copay for ER, and then you have this Part B excess exposure call, which means if you go to a doctor that accepts Medicare, that doctor has the choice to either accept Medicare's reimbursement terms or decline Medicare reimbursement terms. And that's called accepting assignment. So most doctors who take Medicare accept Medicare assignment. There's a handful of doctors that do not accept Medicare assignment. With your Plan N, if you go to a non-assigned Medicare provider, they take Medicare, but they're non-assigned, meaning they don't accept Medicare reimbursement terms. that provider can charge you or balance bill you 15% above and beyond what Medicare agrees to pay. You are responsible for that 15% excess charge. Plan G, Plan F, they cover that excess charge. I get that question a lot. That's why I go into a little bit of detail there. So Plan F, G, N are kind of the most popular supplements on the market. In this area, Virginia, Maryland, you're looking at about 100 to 140 per month. Maryland's a little bit more expensive than Virginia. Then in addition to picking your supplement, you'll be required to pick up a prescription drug plan. There's about 30 different carrier options for this drug plan market. So what we do is we get an updated list of medications from you year to year. We run your list to make sure you're in the plan that gives you the most competitive total cost. We look at premiums, deductibles, and negotiated copays on all of your medications to see who is most competitive based on your specifics. For 2021, the premiums range between about $7 and $100. Most of my clients fall in that $7 to $35 range on the drug coverage. Very rarely do I see a need for the $80 to $100 plan.
Hey, Margo, could that insurance coverage through Part D be a separate carrier than your supplemental?
Yes. So that's kind of the beauty with working with myself, is that I'm not just pushing one product. We get a hybrid. Usually I have husband and wife on the same supplement so that we qualify for any spousal discounts. The drug plans, there's no spousal discount. There's no like bundled package discount. So these are very specific on your medications. And usually I have, I would say 7 out of 10 times a different supplement with a different drug plan. And then husband and wife could have different drug plans because they're on different medications. If you go this route, original Medicare plus your supplement plus your drug plan, and you want dental and vision, this would be a separate private policy as well, in addition to your supplement and drug plan carrier. And the dental and vision policies usually run about 40 to 60 a month per person, depending on the level of dental coverage you're looking for. You don't have to sign up for dental. There's no like enrollment period that you have to meet for the dental. You can pick up dental when you turn 65 or when you enter Medicare, or you can pick it up at a later date. Also, these supplements, the F, G, and N allow for 80% off foreign care up to a $50,000 lifetime maximum. So Medicare will only cover the bill if you are in the US getting care. If you go out of the country, your supplement will have a additional benefit of 80% up to $50,000. And that's per lifetime. So that's one alternative. Option 2, the other alternative, is Medicare Part C, Medicare Advantage product. I will say most of my clients lean in this area because the Advantage plans are a little bit more, I don't want to say expensive, but higher exposure than what you would see in the Midwest or down south. Most of my clients in this area tend to lean towards the supplemental, but I do have plenty of clients in this Advantage plan market. And how these Advantage plans work is you still have Medicare and you're still paying the Part B premium. As soon as you sign up for a Medicare Advantage plan, Medicare outsources its entire responsibility for your care to these Medicare Advantage plans. So Medicare is no longer your primary payer, even though you're paying Medicare. Your Advantage plan becomes the primary payer. So this is where you begin asking providers, do you accept my HMO? Are you in network with my PPO? These are all county and region specific. So if you are moving and you're in an Advantage plan, we have to shop your new zip codes Advantage plan if you move from Northern Virginia to Richmond, you would choose a different Advantage plan because you're in a different market for the Advantage plans. Typically, these Advantage plans are very low premium, $0 to $50 per month in Virginia. Maryland has a little bit higher on premium on their Advantage product in most cases, but typically, I'll just say there's a 0 premium PPO, there's a 0 premium, plenty of 0 premium HMOs in this area. And what happens is you pay 0 for your Advantage plan, but when you begin using care, you're paying co-pays and co-insurance for all services rendered. So if you go in for an MRI, you're paying a copay. If you go in for a hip replacement, you're paying a designated copay or co-insurance. All of your co-pays and co-insurances that you come out of pocket are being added up each month. And when your out-of-pocket maximum reaches a certain threshold, generally between about 4,000 and 10,000, depending if you're in or out of network, your HMO or your PPO is now capping your exposure, and the PPO or the HMO Advantage plan is now paying 100% for the rest of the year. These plans are very similar to group coverage in the benefits that you see. You have co-pays, you have co-insurance up to your max out of pocket, then the plan pays 100%. That is the same setup with your group coverage. The negative to these is that they are networked. So if you choose a hyper-specific HMO and you want cancer treatment out of network, you're 100% on the hook. A big one here is with Kaiser. If you choose Kaiser and you want a non-Kaiser approved doctor, and you want treatment out of Kaiser, you're generally 100% on the hook. HMOs are very specific to their networks. There are very few cases where you can go out of network. PPOs are kind of the hybrid between Medicare Advantage meets supplements. PPOs allow for you to go to any doctor that accepts Medicare nationwide. If you use in-network specific PPO doctors, you get the best deal on your co-pays and co-insurance, but you do have the flexibility to go out of network to any Medicare approved doctor nationwide with your PPO. You'll just pay a higher percentage of the cost. These HMO and PPO Advantage plans also include your dental, your vision, your hearing, in most circumstances. Again, it's product specific, year to year these change, but there's a handful of options that include dental, vision, hearing built in to your Part C Advantage plan. So think of Medicare Advantage Part C, your HMO and PPOs, as combining Medicare A hospital, Medicare B medical, Medicare D drug, dental, vision, hearing, gym, all into one bundled package. So let's talk about kind of the pros and cons and the ins and outs even further. So if you choose Medicare Advantage when you first become eligible and enter Medicare, you generally have a 1-year trial period from the date of your Part A effective date. So if you move into Medicare, you pick up Part A, Part B, and you opt for a Medicare Advantage plan, you have a 1-year trial period to test the waters and see if you like the Advantage product. If you don't, and you're within that 1-year trial period, you can go get out of your Advantage plan and move to your supplement and your drug plan without health questions. Anytime outside of that 1-year trial period, if you want to make a move from Advantage to supplement, you have to answer health questions to move Medicare Advantage to Medicare Supplement. Medicare supplements based on your answers to these health questions can either deny you because you're too high risk and poor health, they can accept you because you're good health, or they can increase your premium based on your risk level. So you could choose this Advantage plan route and find yourself kind of funneled into that Advantage plan product. And if you get unhealthy and you're meeting those high max out of pockets year to year, that's where these supplements look a little more attractive. If you stay healthy for 10, 15 years, paying a zero premium, and you go see the doctor once a year, paying a $15 copay, these Advantage plans are excellent. So that's just kind of something to watch out for, is if you ever want to drop your Advantage plan and move to the supplement, you need to be aware that you're going through underwriting. The opposite is not true. If you go Medicare supplement and your premiums get too high or unaffordable, or you just see value in going zero premium and having free dental, vision, and gym, and you say, Margo, I want to drop my supplement and drug plan and go to a Medicare Advantage plan, there's no underwriting. And we can do that October 15th through December 7th, which is the annual enrollment, or excuse me, open enrollment period every year. So no health questions to drop your supplement and move Advantage. No health questions to move drug plan to drug plan, but there is going to be a health questionnaire if you move Advantage to supplement. Also, if you choose a supplement and you want to change carriers, you have to answer health questions. So your initial choice of supplement is also very important. And this is where you would want to find a supplement that is well known in the supplement market. Typically, we see smaller carriers with less risk pool and less market share here increase their premiums quite a bit. So you want to find a carrier with quite a bit of market share and market presence in the Medicare supplement arena. Okay, so again, just a quick review on periods of review. When you opt for Medicare and move in, when do you review your plan? So every client of mine will get an email and a letter about 3 to 4 weeks prior to October 15th, asking for updated information and updated review information. So that's October 15th through December 7th. Every year is a time to rate shop your drug plan to drug plan or Advantage plan to Advantage plan. Any changes you make during that annual enrollment period will take effect on January 1st of the upcoming year. Then January 1st through March 31st, you'll have an open enrollment period where if you move to a Medicare Advantage plan from your supplement, you can drop that Advantage plan and go back to your supplement. And Part D, you can shop, make a one-time change to your Advantage plan. If somebody razzled and dazzled you and told you to sign up for one carrier, you find out that your doctors are not in network. Now you can go back to a different Advantage plan that will keep your doctors in network. You can make that one-time change during the open enrollment period. Note, supplements, there is no enrollment period outside of turning 65 or coming into Medicare. We can rate shop those anytime throughout the year. You're just subjected to health questions. No health questions when you're turning 65, and no health questions if you're coming off large group coverage, picking up Medicare B for the first time. Also, I have a handful of Fairfax County school district retirees. If you're on a retiree plan, because you're trying to keep your spouse on that plan as well until they turn 65, there's a handful of supplement carriers that will take you coming off of retiree coverage without health questions. So last part of the webinar, hopefully you guys are getting some good information here. Any questions, feel free to shoot them in the Q&A now, but we're gonna dive into IRMA, donut hole, and insulin savings programs. So if you are a high earning individual, if you're making $88,000 or more as a single tax filer, or $176,000 or more as a joint tax filer, then Medicare premiums will be higher. Medicare is always 2 years behind on updating their information. So for 2021, if you're entering Medicare, Medicare will have your 2019 modified adjusted gross income on file. And that's what they're using to set your 2021 premiums. So 2019 is being used for your 2021 premiums. Medicare will automatically update their information year to year with your previous 2-year filing. So in 2022, they'll use your 2020. In 2023, they'll use your 2021 information. They will have no idea if you retire or have a work reduction or a divorce. That's called a life qualifying event. And when we have that life qualifying event, we can immediately tell Medicare to use your expected income for 2021 rather than your 2019 information. So if you're retiring in 2021 or 2022, and you know you're going to have a lower expected income, we can immediately tell Medicare to use your expected modified adjusted gross rather than your filed adjusted gross from 2 years prior. Here's the income chart. You'll see here, if you are a single individual on the far left side column, let's say you're a single individual making between 165 and 500,000. You'll go sorry about that, guys. You'll go all the way over. You're paying the standard $148.50 per month premium, plus an additional IRMA B surcharge of $326 per month to total the $475. Then when you pick up your drug plan, Part D, or Medicare Advantage prescription drug plan, MAPD, HMO, PPO option, you're paying an additional $70.70 per month on Part D. So there's a Part B IRMA and a Part D IRMA. So this is where if you're working after 65, you have group coverage, we're taking these IRMA surcharges into consideration when we're reviewing and comparing your group to your Medicare costs. Also, if you're with us and you're retiring and you're moving into Medicare, we're helping you appeal this IRMA to tell Medicare that, hey, I was making $200,000 while working. Now I'm making, $100,000. Let's knock down my IRMA to a lower bracket and remove some of this IRMA. We will help you navigate that and complete forms and get those forms submitted. All right, donut hole, hang with me here. Donut hole is very confusing. A lot of clients will say, well, I thought donut hole was closed. Donut hole is not closed, it's capped at 25% exposure. So what does that mean? So this chart here is very handy. So any drug plan that you sign up for in Medicare, whether it's Part D drug or Medicare Advantage Part C, HMO, or PPO, you'll have this same setup for drug coverage. So most plans, not all, most will have a deductible phase where you're paying the first 100, 200, 300, or 445 in deductible for the year. Once you meet your deductible and drug cost, so you go fill Restasis, you go fill your insulin, now you're hitting the 445, now you're moving to initial coverage phase. And instead of paying your deductible, you're paying a low copay on your medication. $1, $20, $45 on your tier 1, 2, 3, 4 medication. What Medicare is calculating while you're paying these low copays is the true retail cost. So your plan has a negotiated retail cost. You're paying a copay, your plan is subsidizing the rest. When the true retail cost on all medications filled for the year reaches this 4130 benchmark, you're now put into the donut hole. So if you were on $1,000 medication, by the 4th to 5th month of filling that medication, you've hit your 4130 benchmark. Now you're in the donut hole. Once you hit the donut hole, instead of paying a set copay, you pay 25% of the cost of your medication. So if you're on $1,000 medication, you would pay 25%, $250 until you exit the donut hole. You exit the donut hole when your deductible, what you paid in deductible, what you paid in copays, what you paid in 25% coinsurance, and this opaque manufacturer's discount that's being added in. When all of those reach $65.50 for the year, now you're kicked out of the donut hole or the coverage gap, and you're put into catastrophic coverage. And this is where you pay 5% of the cost of each medication for the rest of the year. These reset on January 1 each year, and everything goes back to that deductible phase. So you pay 5% in catastrophic, your plan pays 95%.
So there's no maximum out of pocket on this component. I mean, if you're out of coverage, that's 100,000 a month because it's a cancer drug. I mean, this could be a huge cost. Am I understanding that right?
Correct. So cancer chemo drugs are typically covered under Medicare Part B. Infusions, those are typically covered under medical Part B. But here, like Restasis is a perfect example. Your Hep C medication, which is like a $75,000 medication, you're in that catastrophic phase immediately paying 5%. To answer your question though, there is no cap on your exposure, nor is there a plan or product in the Medicare market that covers this exposure. And it's a shame because Congress is patting themselves on the back saying, we made changes, we capped you at 25%, we've closed the donut hole. But really it's still an exposure if you are on that expensive medication. Let me just throw this out. There's not a lot of ways to avoid the donut hole. Typically, we would recommend like reaching out to your provider to see if there's an alternative generic. If there's a handful of like Canadian pharmacies that will ship, there's a handful of mail order pharmacies that will ship and avoid this. Depending on your income, you could qualify for a pharmacy assistance program or savings card. Yeah, but aside from that, it's an exposure here. So what to take away? A lot of different moving parts. Generally, an emailed question to me, I can give you kind of a bird's eye view response back. But typically my consulting and my one-on-ones are much deeper. They take more than 15 minutes if you're moving into Medicare. Get the ball rolling early. Medicare is delayed because of COVID. Your IRMA appeals are delayed. Most of these offices are backlogged. There's a ton of people turning 65. So I always recommend starting this process earlier rather than later. With that being said, if it is a last minute move into Medicare, we can make things work. We can do our best to line everything up accordingly. But I typically recommend about 6 to 12 months out from your birthday, just starting the conversation, knowing that your enrollment window really begins about 3 months prior to your desired effective date or 65th birth month. Let me just go back to the beginning slide here because that will have office number, cell phone, and email, and our website. If you guys hop on our website, we have a ton of blogs, webinars, just general information. We link a lot of it through Medicare.gov, so you're getting authoritative information. Our whole goal here is to have transparency and educate our clients. I often get a client call and say, okay, let me hear your sales pitch. For me, it's not a sales interaction. It's really educational by nature. This is a brand new market for many of you. If you were coming off group, you never had to shop your group coverage. So you're really starting at an elementary level coming into Medicare. So that's something I take pride in is being educational with our information.
This is great, Margo. Fantastic information. We had one question that came in from a participant, which was around Medicare Part B and TRICARE for Life. Any thoughts there or comments that you want to share?
Yep. So if you have TRICARE for Life, you're going to sign up for Part A and Part B only. And then your TRICARE for Life will work just like your supplement that I mentioned here. It'll cover all the gaps in Medicare. It'll cover your drugs. If you have access to TRICARE, it's an excellent product. You don't need anything that's ancillary to Medicare. Just sign up for A and B.
Perfect. And then I had a question on kind of the logistics of if you go the supplemental route versus the Medicare Advantage route. In terms of the timing, whether you go with the supplemental or the Medicare Advantage, are you always still signing up for Part A and Part B first? Like, at what point does the handoff occur with the Medicare Advantage plan specifically?
Yeah, so in order to enroll in the Advantage product, you have to be enrolled in Part A and Part B and have a Medicare number.
Okay.
With the supplements, we can start your supplement enrollment about 6 months from your effective date for Medicare A and B. They don't need to see proof that you've enrolled in Medicare A and B. But the drug plans, the Medicare Advantage plans, they all need to see proof that you've started your Medicare A and B enrollment, that you have a Medicare number assigned to you. So kind of the logistics and timing is, let's help you sign up for Medicare A and B first. And then about 2 weeks later, you should have an online uploaded Medicare benefit verification letter. And Medicare enrollment is all through your Social Security SSA.gov account. So you need to create a SSA.gov account in order to sign up for Medicare. Once you do that, about 2 weeks later, you'll have your Medicare benefit verification letter. And that letter can serve as proof because you won't have your card yet mailed to you, but that letter will have your Medicare number, your A/B start date, and serves as proof until you get your mailed card, which could take 2 to 3 months. And Social Security and Medicare offices, half the reps there don't even know that there's a Medicare benefit letter.
Right.
So if there's any uncertainty, again, we are kind of just a middle resource. If you're getting kind of a runaround from Medicare, you can give our office a call and hopefully we can point you in the right direction. But 3 months out from your birth month or your desired retirement date, you'll start the Medicare A/B process. 2 to 3 weeks later, you'll have your Medicare number, and that's when we can finalize your supplement, your drug plan, or Advantage plan.
Perfect. That's super clear. I just want to make sure, because I know people kind of trickled in over time. If anyone has questions, we have a few minutes left for Margo, you can put them in the Q&A. Otherwise, Margo, the best way to reach you, it sounds like, is either to call the seller office or email you. Is that right?
Correct. If you call the office, then my team can coordinate like a one-on-one phone call, or if you shoot me an email with some questions, I'll spend some time answering those.
Okay, perfect. Thank you. So let's just give it a minute for people to type in questions. But this was really, really well done. And there's actually a lot of webinars that Margo's done, and maybe your brothers or other people at the agency have done that can be found on their website if you're looking for even more information. So someone asked, can we get a copy of the slides?
Yeah, I can send you a PDF of all the slides, and you can send those out to everybody that attended, or if you shoot me an email, I can send it as well. Whatever's easiest for whoever's asking the question.
Okay, yeah.
Yes, we can get you a copy.
Okay, perfect. Any other questions? It's a lot of information. All right, here are a couple come in here. Are you doing in-person consultations with fully vaccinated people?
Yeah, we have conference rooms here with a lot of space. I'm fully vaccinated, so if you want to come in, we're more than happy to accommodate. Honestly, I think I've seen one person in person over the last few months. So most of what I do is remote and Zoom, but I'm happy to have somebody come in. It's so well, even before COVID, I did mostly remote. I find a lot of East Coast clients just didn't want traffic to deal
Sure.
with. So, but yes, I'm happy to do in person.
You can do it either way, which is great, and that's how we're working too. We're finding a lot of clients as we've kind of starting to come out of COVID. Zoom has become almost a habit now. So either way is fine for us too. A couple other questions here.
Yep. So I see the question
Okay.
of the $445 per year deductible. So the Part D deductible, that's the max a plan can charge you. So a Part D prescription drug plan cannot have higher than a $445 deductible. Not all plans have that high of a deductible. The cheaper ones, yes, but the middle price ones will have kind of a $200 to $350 deductible. The very high premium plans, 50 to 100, will have a $0 deductible.
And do you see this other question, or do you foresee it's a little bit of a bigger one to tackle? Any changes in the Medicare for the administration?
I could see Medicare premiums increasing as more and more individuals are aging into Medicare. It's having more of a cost on the system. So I could see the premiums increase. No, and a lot of these Medicare Advantage plans are receiving subsidy from the government. So if there's any change to that subsidy to these Advantage plans, we could see a change in the Advantage plan pricing. But honestly, this year was the first year that I saw such a significant push by these Advantage plans on TV, on the radio, for enrollment in the Advantage plan market. If you go to, it's Kaiser Family Foundation, they are pushing for Medicare Advantage plans. And I think there's just this general attitude towards the Medicare Advantage market because it's cheaper on the Medicare system as a whole. If Medicare can take their entire cost financial responsibility and put that onus on a private Advantage plan and pay that private Advantage plan less than what it would actually cost them to manage your care, they're incentivized to, I don't want to say steer you towards Advantage, but it's a cheaper exposure for them if you select an Advantage plan. So when you call Medicare, let's say you didn't have a broker, their Medicare reps are naturally pushing for the Advantage product. The supplements are still putting the onus on the Medicare as a whole. Medicare covers 80% of your bill if you choose Medicare with a supplement. So just being in the market for the last 10 years, I do see for the first time in a very long time, a very heavy push and just steering towards this Advantage product, even though it's not the best coverage. A lot of clients will hold on to their supplement regardless of price, but those supplements do increase by about 3 to 7% per year. So by the time you're 80, 90 holding on to a supplement, that's where those Advantage plans still look pretty attractive compared to a $300 premium per month. But aside from that, I haven't heard of any significant changes. I think the biggest buzzword right now is prescription drug coverage and this donut hole and this exposure and changing how this entire system works. So that's something that we can all keep our eyes and ears tuned into.
Are there a lot of the carriers who are in the Medicare Advantage plan, Margo? Are they also in the Medigap space? Like, do they do both, or is it tend to be either one or the other with the health insurance carriers?
Great question. Majority do both. Care First, Blue Cross Blue Shield in Virginia only does supplement. Kaiser only does Advantage. Everyone else will have Medicare supplement and Advantage. Most will do the prescription drug as well. I would say majority are dabbling in all of the Medicare markets.
Okay. Yeah, it's an amazingly complex space. We had a couple people who said thank you so much. It was super helpful in the chat box. So this was fantastic. I'd love to do it again at some point. So thank you for making the time for us. It was incredibly valuable for me included. So great to have you as a resource, and encourage clients to reach out to Margo if they have questions or want to set up a consultation.
Awesome. Well, it was nice to see you again, and let me know if you guys have any questions. I'll be around. Okay.
Thanks so much, Margo.
All right, bye-bye.
Bye.